Hello, my name is Sunguk Jang. I'm an interventional endoscopist at the Cleveland Clinic Digestive Disease Institute. It is my honor and privilege to share our recent work titled Association of Covered Metallic Stents with Cholecystitis and Stent Migration in Malignant Biliary Stricture in the journal GIE. My colleagues and I would like to convey our sincere appreciation for the opportunity to further elaborate our study via the form of this Meet the Author video segment. The inception of this study began with the observation that the type of self-expandable metal stent chosen in treating malignant biliary stricture depends in large part on individual physician's affinity toward one type, that is covered versus uncovered, based on his or her experiences. Unlike benign stricture where covered stent is used predominantly because of its removability, treatment of malignant stricture does not require self-expandable metal stent to be removed after a certain interval. Thus, whichever stent that provides maximal patency duration should be sought in treating individuals with malignant biliary stricture. Covered metal stent was developed in hopes that it will prolong bile duct patency by preventing tissue ingrowth that could occur in uncovered self-expandable metal stent. However, several recent meta-analyses, as well as well-designed randomized multicenter study, such as one by Coleman and colleagues, comparing covered self-expandable metal stent with uncovered self-expandable metal stent, have shown no benefit in patency duration with the use of covered metallic stent. Then, there is ongoing discussion in regards to the potential of increased risk of cholecystitis with the use of covered metallic stent. This has borne healthy debate amongst experts in the field and studies looking at this specific issue. Juxtaposing this ambiguity of clear clinical benefit with substantially higher cost of covered metallic stent, we felt that clarity in this matter would be helpful. In order to answer the question raised, we collected data from our institution spanning an 8-year period. We amassed a volume of data from more than 600 patients who underwent ERCP with metallic stent placement for the malignant biliary stricture treatment and analyzed data retrospectively. Our study confirmed no benefit with covered self-expandable metal stent in terms of patency duration. We also confirmed substantially higher rates of stent migration requiring revision with the covered metallic stent use. Interestingly, our study demonstrated significantly higher rates of cholecystitis with covered self-expandable metal stent compared to uncovered counterpart. We know that cholecystitis occurs when cystic duct orifice is occluded. There has been theoretical concern that covering material of metallic stent can readily and completely occlude the flow of bile from gallbladder, whereas uncovered metal stent can permit some flow of bile through its interstices. As the rate of post-ERCP cholecystitis with the metallic stent is relatively low, this has been difficult, albeit important question to answer. In the past, small retrospective studies did not demonstrate any difference in terms of cholecystitis rate between covered and uncovered metal stents. However, given small sample size of cholecystitis among relatively small volume of patients enrolled, meaningful interpretation and analysis were difficult. In our study, there were 14 occurrences of cholecystitis among 457 patients with gallbladder in situ, translated into 3.1% of cholecystitis rate. The rate of cholecystitis was significantly higher in covered metallic stent group than uncovered metallic stent group. The rate of cholecystitis in the covered metallic stent group was 7.8% compared to 1.2% in uncovered metallic stent group. Even with this number of cholecystitis occurrence, multivariate analysis was difficult, which is one of this study's limitations. Nevertheless, the observed difference is significant enough, and there is a plausible physiologic explanation behind our finding, that covering of self-expandable metal stent will make the complete occlusion of cystic duct orifice much easier. To answer some of the questions raised from earlier studies, We also looked into the presence of cholecystitis as a potential risk factor for a post-self-expandable metal stent placement cholecystitis. Our study did not find the presence of non-obstructing gallstone to be a risk factor for development of post-metal stent placement cholecystitis. We believe the significance of our finding can aid in providing clarity in terms of choice of metal stent use when treating biliary stricture of malignant origin. Self-expandable metal stent was created to provide longer patency duration compared to its plastic counterpart. This has been clearly demonstrated. With the continued improvement of medical regimen, patients who are suffering from malignant disease resulting in a biliary stricture can live longer, sometimes outliving the patency duration of metallic stent. With affirmation of similar clinical efficacy in terms of patency duration, with higher rates of stent migration and possibly increased risk of cholecystitis, the judicious use of cover self-expandable metal stent in patients with gallbladder in situ is warranted. Existing GI Society guidelines, a European Society of Gastroenterology, for example, does not favor one type of self-expandable metal stent over the other in treatment of malignant biliary stricture. Perhaps it is time for us to consider selective use of self-expandable metal stent based on the type of stricture in patients with intact gallbladder. One aspect that cannot be neglected is a cost perspective. Cover self-expanded metal stent routinely costs more than its uncovered counterpart. We as physicians also have to be mindful of healthcare costs that incurs to our community and choose what is best suited. Clearly, a large prospective, possibly randomized study will be of a great value. Nevertheless, this study, which is one of the largest in its kind, generated thought-provoking findings that can translate into practical application of our patient care. And we are humbled and excited to present our findings to our esteemed colleague through a prestigious vehicle that is GIE. Thank you.